Hello, my dear doctors. Welcome to SsAcademy International MRCP Part-1 online course. Yes, my dear doctor, listen very carefully. The lecture note discussion is very much important. The lecture that I'm going to do. We have given a name, the lecture notes discussions, my dear. So I'm going to discuss the lecture notes that is provided to you, my dear. My dear, listen very carefully. In this lecture note discussion, the most important thing that you will know, my dear, yes, you'll see the topics overview, means the content list that I have given here. So you'll have an overall idea. Number one, firstly, you'll have an overall idea what topics are discussed and what topics are very important in this chapter. Means I'm telling you what topics are important, my dear, to know. Means what topics you need to study, what topics you need to study less. So based on the extent of the importances, we divided the topics into the 5-star, 4-star, 3-star, 2-star and 1-star, my dear. So the 5-star topics is recommended for studying for the 5 times, 4-star 4 times, 3-star 3 times and 2-star 2 times and 1-star 1 time. Means perseverance, as I said in the introduction part, my dear, you need to go through them at least the 5 times study, my dear. So my dear, listen very carefully. In these lectures, you'll get the number one, the overall idea. Number two, you will have the extent of the importances that are nothing but the 5-star, 4-star, 3-star, 2-star, 1-star. Means you will get the star, my dear. Thirdly, this is important. Yes, mostly the topics you will get the video lectures, my dear. After having these lectures discussion, you'll have the video lectures. So video lectures topics are usually 3 to 5-star, my dear. Yes, my dear doctor, listen very carefully. The less than 3-star topics are usually discussed in these lecture note discussions. So thirdly, you will get the discussions on less than 3-star topics, my dear. So this is very important to know what star, my dear, because sometimes I will say these topics will definitely be set up in your exam, my dear. So this is important. So the video lectures that you are getting, my dear, the video lectures means me as well in front of the board giving the lectures. Definitely it's a 5-star to 3-star, my dear, the importance is, my dear. So yes, my dear doctor, listen very carefully. And also, sometimes what I do, the fourth importance is that the SsAcademy International always trying to do the update, my dear. So based on the updated guidelines, recent guidelines, it's important for the RCP Royal College exams, my dear. Whatever the exams you're going for, the updated guidelines that you must know. So updated, my dear. So updated guidelines will be included here and some updated notes will be provided to you, my dear. So yes, let's get back here. So starting with the contents, my dear. You see the content here. So you see the topics here. You will see the button here, the play button, my dear. You see the play button topics are basically the video lectures. And second lectures, you see the mic button. And these mic buttons are basically the lecture screen recording. I say the SCR lectures, my dear. It means the screen recording lectures, my dear. So you will see the button like the play buttons. The play buttons are usually the 5-star topics. This is important, my dear. 5-star topics that you'll get, my dear. And the lectures are given like these. These buttons are usually the screen recordings, and these screen recordings are also important. These are basically 3-star to 2-star topics, my dear. And other topics I'll discuss here very quickly, very short, and giving some an overview, very quick idea of the full lectures, what you're going to do, my dear. Yes, my dear, let's start. So is the opening door for the lectures discussions, my dear. You see the content list is given here under the headings of different diseases. So starting with the first disease, you see the Paget's disease of the bone is a very important topic, my dear, 5-star. So when I say the 5-star, so you will write down the 5-star here. Yes, my dear, you see the 5-star. So you have to write down the 5-star here. Yes, my dear. So the way I'm writing the 5-star, you will start with the 5-star here. So let's get back the discussions. Definitely you'll have the video lectures because you have seen this. This is the button here. This is called the play button, my dear. So the play button indicates you'll have the video lectures. So definitely it's very important, very good discussions. But the recent guidelines has taught some important talks, my dear. You see the investigation, this part, the yellow sheets. So you see the yellow colored highlighted things are new things are updated, my dear. So I'm getting some updates, my dear. So you see the blood test, you see the raised alkaline phosphatase, calcium and phosphate typically normal. Hypercalcemia may occasionally occur with a prolonged immobilization. You will have a lectures in clinical science chapter, my dear. Yes, there you'll get definitely an idea of the calcium, phosphate, and definitely the calcium abnormalities in the different diseases, my dear. Here are the other markers of the bone turnover. Because the bone means the osteoclastic destruction of the bone leads to the different materials will be in the blood, my dear. So these are the pro-collagen type 1 N-terminal pro-peptide, my dear. So I have given a name, the PIMP. You see the PIMP. Serum C telopeptide. So once again, you see that telopeptide CTX, but it is a peptide. Urinary N telopeptide, once again the peptide. And urinary hydroxyproline. So another proline. So these are the urinary, and this is the serum marker. So these are the new things, my dear. So once again, as I said, you'll see that in the video lectures, Paget's disease is a PAPA disease. So definitely the PAPA, you will see the PAPA, the meaning of the PAPA. PAPA is a P for pain, P for, yes, pathological fractures. You can write on the pain. And pathological fractures, and definitely this PP, pathological fractures, and these 2P that I'm included here, and other 2P that I'm adding here. Yes, as I said, the P for phosphatase means the alkaline phosphatase. Write down the box, my dear. Phosphatase means the alkaline phosphatase, and urinary hydroxyproline. So this is the box, you'll get the SS box, my dear. So urinary hydroxyproline. So blood alkaline phosphatase will be raised, and urinary hydroxyproline. Other than these 2P that I'm adding now, yes, my dear, this is very much important. So PIMP, once again the PIMP. Another one is the serum C telopeptide. So I'm writing the peptide. So you write down the CTX, C telopeptide, yes, and urinary N telopeptide. So these are the serum, 2Ps, and urinary 2Ps along with the proline, but this is the N telopeptide. Once again, peptide, you will write on the way I'm writing peptide, N telopeptide, yes, my dear, and definitely proline. Yes, my dear, proline. So this is the box that you need to learn, my dear. Yes. And last P is the PAPA disease. Once again, the phosphonate means the bisphosphonate is the treatment of choice, my dear. You need to write down the phosphonate. So bisphosphonate. So you see the pain pathological fracture, phosphatase proline. The box you'll get in the SS boxes, but I'm adding this. This is the box that you need to add, the PIM peptide. Once again, peptide proline. PIM peptide, peptide proline. PIM peptide, peptide proline. Once again, PIM peptide, peptide proline. So you need to remember this serum PIM is the serum PIM, and the serum C telopeptide, and urinary N telopeptide, and once in the hydroxyproline, my dear. So these are the markers that you need to learn, my dear. And last is the treatment is the P for phosphatase, is the bisphosphonate is the treatment of choice. So this is the updated things, my dear. You must know. If you want to know only the single word, my dear, I'm telling you, only the PIM that you need to remember. PIM, my dear, I'm saying. Yes. Now get back, other things will be discussed in the video lectures. So you see, yes, my dear, some photography is given here. This is important. The radiograph demonstrates the marked thickening of the calvarium. You see the thickening here. You see the thickening. Yes. This is also marked thickening. You see. There are ill-defined sclerotic and loosened areas throughout. These features are consistent with the Paget's disease. So, Paget's disease radiological picture, my dear. So, if you write on the box and the box of the radiological box, Paget's disease radiological box. Once again, yes, my dear doctor. So you need to write down if the patient comes up with the initial point. So you'll get the loosened. If the patient comes late, you'll get the sclerotic lesion. Now, question why? Because you will be learning in the video lectures, you'll see the Paget disease is the osteoclast, means the osteoclastic destruction of the bone mitre, means the osteoclastic. Means Paget disease starts with the osteoclastic destruction. So that's why initially if the patient comes, you'll get the radiolucent areas, my dear. If the patient comes late, osteosclerotic, why? Because the osteoclastic, P for Paget disease, osteoclastic bone resorption destruction stimulates the osteoblastic bone formation, the new bone formations matter. So yes, the osteoblastic leads to the new bone formation, that leads to the sclerotic. If the patient comes in the middle stage of the disease, you will get, my dear, the mixed, definitely the mixed, the lucent and sclerotic lesion, my dear. So this is the things that you must know before going to the radiological changes of the Paget disease, my dear. You'll have the video lectures, you'll understand much more, my dear, because I have given the pathophysiology of the Paget disease very, very well, my dear. You'll understand. So once again, initial lucent, late sclerotic, mixed, yes, my dear, in the middle of the bar. So you see, there is another photo, yes, you see, the pelvic x-ray from an elderly man with Paget disease. There is a smooth cortical expansion of the left hemipelvic bones, yes. You see the left hemipelvic is more expanding than that of the left side. And also diffuse increased bone density. You see the diffuse increased bone density. And coarsening of the trabeculae. Yes, you see the coarsening of the trabeculae. Yes, my dear. And also the another bone scan is really important to see the differences in between the normal and abnormal in Paget disease. You see the isolated bone scan from a patient with the Paget disease showing a typical distribution in the spine, asymmetrical pelvic disease, and proximal long bone. You see the asymmetrical long bone, proximal long bone. Yes, asymmetrical, you see, sclerotic lesions, you see. So these are typically Paget in contrast to the normal people here. It's important, my dear. Yes. So this is the things, my dear, Paget disease will be discussed in the video lectures, and the boxes that I have given, the two other boxes along with the pin that you need to remember the radiological changes. You need to learn the initial lucent, middle mixed, and late in the sclerotic lesion. And next is the autoantibody is a very hot topic for the exam. Definitely more than 5-star, my dear. You have to give the more emphasize on reading this topic, my dear. Very good discussions you'll get, my dear. And ANCA also more than 5-star, also more than 5-star. Yes, and definitely the extractable nuclear antigens antibody is also the 5-star, more than 5-star. It's a very hot topic for the exam. And then the discussion, the rheumatoid arthritis, the rheumatoid arthritis epidemiology is 1-star, but the rheumatoid arthritis is more than 5-star. Yes, the rheumatoid arthritis diagnosis once again more than 5-star. Based on the new guidelines already discussed in your video lectures, rheumatoid arthritis prognostic features is also 3-star or 4-star, Yes, you need to write them down. Sometimes you can ask what the benefit of writing this star, Star is important because whenever you are revising after finishing all the chapters altogether, it will be beneficial, to which topics that you need to focus on and to which topics you need to focus less. Yes, my dear. Coming back to here, the RA management is also the more than 5-star. More than 5-star is very much important. Here is the choices of initial. Yes, my dear. One updated has been come, so that's why I've been discussing here a little bit. Yes. DMARD monotherapy. You see the hydroxychloroquine, I put the chloroquine, should only be considered initial therapy if mild or palindromic disease. Yes, my dear. So the mild disease, yes, hydroxychloroquine. This is important. So initial therapy only when you can choose it as the initial point, only the mild disease. So you can write down the lindromic or less disease, means the chloroquine. You can write down the chloroquine equal to less, means the mild disease, or palindromic means the lindromic. Yes, my dear. So these are updates, so that's why I've discussed here. Other things will be discussed in the video lectures, my dear. Important lectures. All the things about the sub, rituximab is a very hot topic, 5-star topic, my dear. Once again, the methotrexate is a very hot topic for the exam with the 5-star once again, more than 5-star is a very hot topic. Every day you'll get the questions from here. The one of the update here, you see the adverse effects, the pneumonitis. Yes, my dear. The updates in the most common pulmonary manifestations. Similar disease pattern to the hypersensitivity pneumonitis secondary to inhaled organic antigens. The similar disease pattern to hypersensitivity pneumonitis. Yes, my hypersensitive pneumonitis typically develops within a year of starting treatment, either acutely or subacutely. This is important. So acute or subacute disease rather than a chronic disorder presents with the non-productive cough, dyspnea, malaise, fever, and they leads to the pulmonary fibrosis and liver fibrosis. You'll have good discussions, but this is the important things, my dear. Means you can write down the MTX, means the methotrexate pneumonitis. So methotrexate pneumonitis is very close to hypersensitivity pneumonitis. You need to write down. And yes, once again, within a year, just write down a box. Within a year, the disease can start either acutely or subacutely. So the acute or subacute presentations, my dear. Acute means, once again, acute means within hours to days, and subacute means days to weeks, my dear. So MTX pneumonitis is the most common pulmonary manifestations done by the methotrexate rather than the pulmonary fibrosis and other manifestations. But the MTX pneumonitis is a very hot topic for the exam. Once again, if the pulmonary manifestation, the patients after having the MTX, you see it is written within a year. So within 1 year of using of the methotrexate, the patients develop the cough, sputum, sometimes the non-productive cough, and the dyspnea means the shortness of breath and exhaustion, sometimes the fever. So these are the symptoms. Means the pneumonitis, the lung infection like, but the non-productive cough. This is important. Yes, my dear. Then you can think of the MTX pneumonitis. Hydroxychloroquine is also very hot topic of the exam. This is 3-star to 4-star topic, my dear, very hot topic. Once again, the drugs are very important. 3-star, leflunomide, or 4-star topics, my dear. The video lectures you'll get. Sulfasalazine, once again, this is the 3-star to 4-star lectures, my dear. You'll get, my dear. Tumor necrosis factor, once again, the 3-star. Yes, my dear, 3-star topic. You'll get, my dear. And here is an important thing. So you see that TNF is important pathogens in number of inflammatory conditions such as the rheumatoid arthritis and definitely the Crohn's disease. So that's why TNF inhibitors are therefore now used for the variety of conditions. So another drug has been coming, my dear. So TNF inhibitors, definitely you know about the infliximab, etanercept, adalimumab. But the golimumab, yes, my dear, golimumab is a subcutaneous, yes, the new TNF alpha blockers used in the, of course, the rheumatoid arthritis and the Crohn's disease. Yes, my dear. So you can write on the TNF, yes, the RA, rheumatoid arthritis, and the Crohn's disease. The way I'm writing the boxes. And the drug, the new drug is definitely, you know, the infliximab. We have put the infliximab, definitely the etanercept. We put the name, the etanercept, and adalimumab. These are the drug, my dear. Along with that, the golimumab, my dear, is a new drug, golimumab. It's a golimumab. Golimumab, the new drug, is the TNF alpha blockers. Next to the RA complications, yes, my very hot topic is more than 5-star topic. Once again, it's a very hot topic. Sometimes I used to say the 7-star. You'll get the questions from here, my RA respiratory manifestation is also very important, 5-star. Once again, and RA ocular manifestation, once again, the 5-star topic, my dear. Yes, very important topic, 5-star. RA X-ray changes, once again, more than 5-star, I must tell you. Yes, my dear. RA pregnancy is a 2-star to 3-star topic, my dear. 3-star, you'll get the lectures, my dear. Yes, my dear. So cryoglobulinemia is a very hot topic for the exam. I would love to give the 3-star for part 1, but the part 2 is very hot topic for the exam, my dear. Sjogren syndrome is more than 5-star. I must tell this 7-star topic, my dear. 7-star. Once again, the SLE definitely is a more than 5-star. The discussions, the video lectures you'll get, my dear. Dark-induced liver is more than 5-star. It's very hot topic with the exam. It's a very good discussions. You see some photograph here. The woman with the drug-induced lupus. Yes, my dear. So this is the drug-induced lupus. You can see the butterfly rash. Yes, my dear. Drug-induced lupus. The drugs are here. The SLE, the clinical features are given here. So this is basically 3-star. the clinical features and pathophysiology, what is given here. So you need to remember the SLE is a type 3 hypersensitivity reactions. As with the HLA, B8, once again, DR2 and DR3, thought to cause by the immune system dysregulation leading to the immune complex. Immune complex deposition can affect any organ, including the skin, joints, and kidneys and brain. Systemic lupus erythematosus features, once again, the features you can see, this is also triple star, basically, and the discussions will be given to you. Lectures, once again, you'll get the lectures. SLE investigation is more than 5-star. I mastered this 7-star rather than 5-star. It's very hard to be with the exam. SLE management, yes, my SLE management is also very important, but I'm giving here for the 3-star. You need to know a little bit. So the basics, the NSAIDs for any pain, but the most important treatment, the treatment of choice, you must remember the hydroxychloroquine is the treatment of choice for the SLE, especially the serositis and arthritis, especially the arthritis, the mucocutaneous, and along with the joint inflammations features, right? So the SLE, you need to remember, is the chloroquine miter is the treatment of choice. And other than SLE treatment, yes, the hydroxychloroquine. If internal organ involvement, then the like the renal, neuro, eye, then consider the steroids and steroid-sparing agent like the cyclophosphamide miter. So details, the things will be given, but you must remember in part 1, you will treat the patients only by the initial step. The hydroxychloroquine is the treatment of choice, the initial mild disease miter. Early onset steel disease, once again, is a triple star topic for the part 1. Yes, miter, you'll get the lectures there. So don't worry about miter. They're very good lectures for the early onset steel disease will be given to you, miter. One of the 5-star topic, miter. You'll get the questions from here. Get back to SLE pregnancy, once again, is also very important 5-star topic, SLE pregnancy. Yes, minor. So it's written here, the risk of maternal autoantibody crossing the placenta. And this is the ROSA. I talked about it. ROSA has got the heart block. So you need to remember the next is the ROSA. Yes, ROSA has got the heart block. ROSA has got the heart block. Means your friends name the ROSA. So you can even the anti-Rho antibody and the name is the ZA has got the heart block. Means if a lady has got the ROSA antibody positive, she will have the chance to deliver with the congenital heart block baby miter. Means this is called the neonatal lupus miter. Yes, this is called the neonatal lupus. Yes, miter. So this is the anti-phosphorylated more than 5-star topic, but you'll get this lecture in hematology miter. There will be a video lecture in hematology chapter miter, not here. So yes, this is more than 5-star, but the new things updated here. So that's what I'd like to discuss. So anti-phospholipid antibodies, you see, it is said that around 30% people will have the SLE. Patients will have the positive anti-phospholipid antibody syndrome. Means SLE people will have the 30% cases that the anti-phospholipid antibody can be positive. But in these antibodies are anti-cardiolipin antibodies, you can write down. Anti-beta-2 glycoprotein, yes. Anti-beta-2, a beta-2 glycoprotein, yes, antibody, you can write down. So I'm saying the ACA, ABA, yes, minor, and lupus anticoagulant is LUC. So ACA, ABA, so you can write down very clearly. So anti-cardiolipin antibody, anti-beta-2 glycoprotein antibody, so ACA, ABBA, and the LUC, yes, minor, yes. So these are the 3 antibodies altogether, you'll get it, minor. So other things will be discussed in the video lecture. Discoid lupus will get the dermatology. This is also triple star topic, minor. In Dharma, you'll have the lectures for the DLE, minor. Some photography is given here. Next is the SSC, the more than 5-star topic. SSC, systemic sclerosis. Once again, the conditions is definitely more than 5-star discussions. Here is a very important things. Patients with the renal disease will start the ACE inhibitor. So once again, SSC, one of the bullets or box, you can say the SSC plus the renal, you should start the ACE inhibitor. Yes, Micah. You need to write down SSC inhibitor. So this is one kind of bullet smile. Next to the, yes, here is another, as with the high risk of severe interstitial lung disease. This is important. Of course, the anti-SCL antibodies as well as the diffuse cutaneous systemic sclerosis. And definitely the anti-SCL antibody is separately, because the questions are hitting. So you need to know diffuse cutaneous. We know about it, the diffuse cutaneous SSC is more organ involvement. So diffuse cutaneous, of course, these are anti-SCL70 antibody, but these antibodies strongly associated with the interstitial lung disease also. So basically systemic sclerosis will see the different organ system involvement. So severe, this is important, severe ILD, severe. So the severe ILD or severe pulmonary fibrosis will be associated, my dear. Yes, my dear, this is very much important. Crystal arthropathy is very hot topic for the exam. Septic arthritis in the adults, my dear, the 5-star. More than 5 stars, very hot topic for the exam. Some updates are coming here. So some investigation definitely will do the, whenever you suspect the acute arthritis or acute monoarthritis, definitely the septic is the first cause. And you should take the fluid from the joint, my dear. This should be done prior to the administration of the antibiotics if necessary. Of course, yes, my dear, you should take the aspiration. So aspiration, and may need to be done under the ultrasound guidance aspirations, right? Shows the leukocytosis with the neutrophil predominance, of course. And gram staining is negative in 50%, means half of the cases you'll get the gram staining is negative. And culture is positive, fluid culture, once again, in patients with the non-gonococcal septic arthritis. This is important, my dear. So important talk means the aspiration fluid study. Whenever you fluid study aspiration, and definitely aspiration is the first step whenever you thought about the monoarthritis, my dear. Monoarthritis, aspiration fluid and the fluid study should be done. And these fluid studies say that definitely under ultrasound guidance, fluid study should be done. And there we can expect the neutrophilic leukocytosis. And we have seen the gram staining. This is important. 50% cases can be negative, my dear. That's important. So we can get nothing actually. So culture and culture for the fluid culture, that is important. Fluid culture will be positive in patients with non-gonococcal septic arthritis. So fluid culture positive. This is the one of the message. If you do the culture, we can get the non-gonococcal septic arthritis. We can expect some culture can be positive. So these are the some pitfalls, some positive things that you need to know, my dear. And of course, along with that, this is important. The blood cultures, you see, is a hematogenous spread. So the septic arthritis, we can do the fluid study, and definitely along with the blood also we'll see some of the blood markers, means the CBC, ESR, CRP. There is also neutrophilic leukocytosis, ESR raised, CRP raised. Along with that, the blood culture is also can be positive by the most common cause of septic arthritis, the hematogenous spread. So the blood cultures can be positive in case of septic arthritis. So yes, this is important, my dear. Yes, this is the update that you need to know. And next, the gout features, once again, is a 3-star. So here is important things, some updates that you need to learn. So these are 5-star, the uric acid, nice, the measuring the uric acid levels in suspected gout in the acute setting. Uric acid level you should measure, my dear. So it's more than 360. Since it's supporting a diagnosis, yes, more equal. And uric acid level less than 360 during a flare, and the gout is strongly suspected. Repeat the uric acid level. So circle the repeat. And measurement at least 2 weeks after the flare has settled. So this is the new things, my dear. So we need to remember the uric acid acute setting, uric acute. So you need to remember the 360 by 2, my dear. This is important. So what does it mean by the 360? 360 means the serum uric acid more than 360. You should support the diagnosis acute gout. And whenever the less than 360, you wait for the 2 weeks, and after that you measure once again the serum uric level, my dear. Synovial fluid analysis. Of course, we know about the needle-shaped crystal, negatively birefringent crystals, is the monosodium urate monophosphate, the mushroom crystals under the polarized light. That is important. The needle-shaped crystal, negative crystal. So urate is a negative crystal, my dear. You'll have a video lecture, my dear. So these are the updates that you need to learn. Here are some of the photographies I'd like to discuss a little bit. So the X-ray of the patients with the gout affecting his feet is demonstrated the juxta-articular erosive changes. Yes, my dear, the erosive changes. So here you can see this is the, yes, So juxta-articular, some erosive changes you can see. So erosive changes, the first MTPs, this is important, joining the overhanging edges. You see the overhanging edges. Yes, my dear. These are some overhanging edges. And as with the moderate soft tissue swelling. So this is the moderate soft tissue swelling. The joint space is maintained. That is important. So the thing is the erosive changes, and definitely the first MTP. Yes. Next is the X of the patient, the gout affecting his hands. So as I say, the G out is the punched out lesion is the typical pictures, but there are multiple periarticular erosions bilaterally that adjacent large soft tissue masses. You see that? Yes. Here is also soft tissue masses and relatively preserved joint space in the right hand. These findings are most predominant. Yes, my dear. At the first interphalangeal and second to fourth proximal interphalangeal, and first to third metacarpophalangeals and carpal joints. So here is also, you see, here is also see, first, second, here is also the swelling, you can see. So yes, you can see. So this is the pictures that have a quick overview in the photograph so that you can make the things to be easier. So this important gout predisposing factor is a 5-star, more than 5-star. More than 5-star topic, more than 5-star, yes. And get to down once again, the gout drugs cause is more than 5-star topic. It's a very good discussion that you need to learn. Get back to the gout management once again. It's a very hot topic for the exam, more than 5-star. The 7-star, you must tell the diagnosis. Here is the colchicine. Colchicine is update the yellow color stain here. So yes, the inhibits the microtubule polymerization. So colchicine, by binding the tubulin, yes, if I'm saying the colchicine, polymerized by binding to tubulin, interfering with mitosis. So the mitosis inhibition also inhibits the neutrophil motility. So I'm putting the motility, mitosis, and merization. So the three important names that you need to remember, you see. So the colchicine, I put the molchicine, merization, mitosis, motility. Once again, merization, polymerization, mitosis, and M for motility that you need to remember. Yes. Now maybe associated the caution in the renal impairment. Of course, the colchicine caution in the renal impairment. The BNF advises to reduce the doses of EGFR. Yes, if EGFR is a 10 to 50, and to avoid definitely less than 10, you should avoid it and you should stop. You shouldn't use this one either. So caution in renal impairment. So yes, the molchicine, merization. Once again, the box that you need to learn, you have to get back to the three words like merization, mitosis, and motility. Merization is the polymerization. So it means the microtubule merization, polymerization. So you can write in the molchicine, microtubule, polymerization, mitosis, and the motility. So the three M's that you need to remember, my dear. So yes, the box, once again, this is box. And adding to the new added things that you need to learn, my dear, from here. Here is the lower target uric acid level below 300. Yes, the target level less than 300 micromoles we consider for the patients who have a TOFA. So TOFA shares gout, is a chronic gouty arthritis and continue to having ongoing frequent flares despite having a uric acid below the 360 micromoles. So the target is important. So target level is less than 300 micromole, my dear. So yes, target is at 300. So hyperuricaemia, once again, the triple star, and the causes here, and the drugs causes, and the shear gout, once again, more than 5-star. Yes. And the low back pain, once again, back pain is very important hot because exams, once again, my dear. 5-star. Yes, my dear. Low back pain is one of the most common presentations, and in practice, while the majority of the presentation with non-specific muscular nature, it is worth keeping in mind possible causes which may need to specific treatment. So the red flags for the low back pain. So start with the red flags. So you see the extremes of the age less than 20, more than 50. So you can say young, old, and history of the previous malignancy. And you see the night pain, nocturnal symptoms is an organic and sinister pathology, my dear. Always remember it. And if any history of trauma and systematically means the fused bundle back, I'm telling you the systemic features. So what is that? So we can write on the red flags. It's a box. This is box mitre. The red flags. Red flags. You will write on the young, old. Yes, young, old, malignancy, night, few trauma, or few night trauma. You can write on the few night trauma. So these are the red flags, the box mitre right now. Young, old means the less than 20, more than 50, malignancy. Young, old, malignancy. Fuse means the fever, fatigue. F for fever, F for fatigue, weight loss, and S for sweating mitre. So these are the symptoms, usually the systemic symptoms, the malignancy which is actually sounding. So the fuse and N for once in the night and trauma. Yes, you can remember fuse night trauma. So the young old malignancy, fuse night trauma. So once again, young old malignancy, fuse night trauma mitre. So there are some causes of the specific causes. These are sometimes questions for, yes, the low back pain mitre. But I would like to talk a little bit further. The low back pain mitre, remember, is very much important. I will discuss later on, but going to the lecture notes what is written. You see the different specific pain, the facet joint. Facet joint is one of the maybe acute or chronic pain worse in the morning and on standing. Yes, mitre. And on standing. Standing means basically, typically works on extension of the back. So I put E for facet, E for facet, E for extension. The single word that you need to remember. On extension, there may be pain over the facets. There may be pain and tenderness over the facet joint, facets, mitre. The pain is typically worse on extension of the back. So the facet extension. Yes, mitre. The spinal canal stenosis. Spinal canal stenosis is a very hot topic of the exam, very, very important. The 5-star topic mitre. Usually gradual onset. Sometimes the unilateral or bilateral leg pain with or without back pain. So the spinal canal stenosis, the leg pain mitre is important. With or without back pain. Numbness and weakness, which is worse than walking. So yes, spinal canal stenosis is worse than walking. Resolves when sits down. Pain may be described as aching, crawling. Yes, mine. And relieved by sitting down. Yes. Relieved by sitting down, leaning forwards and crouching down. So it helps the spinal canal to get the more space mitre so that you can relieve from the pressure from surroundings of the spinal canal. Feel relieved. So it is really relieved by sitting down. So yes, this is important mitre. Sitting down, leaning forwards, crouching down. Clinical examination is often normal. Requires MRI to, yes, the diagnosis. Next is the ankylosing spondylitis, a seronegative spondyloarthritis, a young man who presents with low back pain with the morning stiffness. It works in the morning and improves with activity. And sometimes the peripheral arteries is 25% more common in females. And the peripheral arterial disease, the vasculitis, means the vascular disease, the pain in walking relieved by rest. Yes. So it's a claudication pain mitre, absent or weak foot pulses, circle the pulses and other signs of the limb ischemia. Past history including the smoking and other vascular risk factors can be present mitre. So another things might the low back pain due to the prolapsed disc, lumbar disc is usually produce a clear dermatomal leg pain associated with the neurological deficits. So once again, the lumbar disc prolapse is a leg pain rather than a back pain. Yes, mitre. So leg pain. Pain often worse when sitting. Pain often worse on sitting. So this is the prolapsed intervertebral disc. Yes. So you can say the prolapsed lumbar intervertebral disc, PLID, you can say. Prolapsed lumbar intervertebral disc. So this pain, this is important, often worse with sitting. So this pain increase with sitting. So this is the PLID, increased worse with sitting. The table below demonstrates the expected features according to the level of the lumbar prolapse disc. So the disc level that you can diagnose by getting the nerve root compression. So the L3, L4, L5, L1. You know the L3 is a knee. L3 knee, L4, dorsum of the, yes, the foot down to the floor. L4, you say the down to the floor. Down to the floor. 4 is the down to the floor. 3 is a knee. Yes, my dear, remember. L5 is the dorsum of the foot. L5, basically dorsum. Just write it down, dorsum. And S1 is a lateral border. S1 is a lateral border of the foot. So yes, these are the sensations that we can detect, so that we can make the diagnosis of which areas or which levels of the disc prolapsed. You see the S1 is a sensory postural lateral aspect of the leg and lateral aspect of the foot. As I said, lateral. And the dorsum, you see the dorsum of the foot sensation. And then 4 down to the floor, you see the sensory anterior aspect, the knee and medial malleolus. Down to the floor, medial malleolus. And knee, once again, you see the sensory loss over the anterior thigh up to the knee, my dear. And you see the reduced knee reflexes as well. And also a little bit things that you need to learn here. You see the weak hip flexion, knee extension, and hip adduction. So yes, the L4 is a weak knee and hip adduction. So the extra things is the weak hip flexion. So the L3 is a hip flexion. You need to remember. Hip flexion means the hip flexion, knee extension, and hip adduction. Knee extension, hip adduction. Yes, my dear. Just remember the weak hip flexion. Flexion of the hip. 3, flexion. Just remember. Flexion. And L3 is a positive femoral stress test and positive femoral stress in both cases, you see. Yes. In L3 and L4, a little bit differences that we need to learn by differentiating points. The weak hip flexion. Hip flexion, weak hip flexion is a L3. Management, of course, the low back pain, musculoskeletal pain, the analgesia, physiotherapy. NICE recommends the same drugs as the low back pain without sciatica symptoms. Same as for the back pain with the sciatica symptoms. The first line, of course, the NSAIDs and proton pump inhibitors rather than using the neuropathic analgesia. So this is the 5-star. So you need to use the NSAIDs. If symptoms persist after 4 to 6 weeks, then referral for consideration of MRI is appropriate. Yes, my dear doctor, so this is very much important to know the lumbar spinal canal stenosis and also the facet joint. Yes, these 2 things that we need for facet extension, lumbar spinal stenosis. You need to remember. Yes, my dear. Yes. So it is written the increased with standing and relieved with sitting. Just write it down. Same thing, you see. The lumbar spinal canal stenosis. Here is also another lecture. Use spinal canal stenosis. Central canal is narrowed by tumor, disc prolapse, or other degenerative changes. Patient may present with a combination of the back pain, neuropathic pain, symptoms mimicking the claudications as well. Yes, one of the main features that may help to differentiate the claudication, the history, the posture. Positional element. Positional is history, is the positional element to the pain. Sitting is better than standing. Sitting is better. Means, as I said, the spinal canal stenosis SS is increased with standing and reduced with sitting. Yes, my dear. Patients may find easier to walk uphill rather than downhill. May find it easier to walk uphill. So sitting and walk, you need to write down the uphill. Walk uphill. Walking uphill. The neurogenic claudication type history makes the lumbar spinal neurogenic stenosis likely underlying. Diagnosis absence of such symptoms make it far less likely. So neurogenic claudication type history. So yes, when neurogenic means this type, means the increase with standing and reduced with the sitting, and once again the reduced with or relieved with the walking uphill. So this is the story that you need to remember. So pathology, you see the different pathologies are there, so you get through them. Yes, not very much important. The diagnostic MRI scanning is important. Best modality of the demonstrating the canal stenosis historically. Bicycle test was used as a true vascular purification, couldn't complete the test. And the treatment is a surgery, the laminectomy. The spinal canal stenosis, the treatment is the laminectomy. Yes, my dear. So I'd like to talk a little bit further so that you can understand the things better, my dear. Yes, my dear doctor, I will not go for any detail, but at least you need to understand the things better. So you see the facet joint, you see the facet, these are the facet part. So this is the facet joint. So the facet joint syndrome, you see the facet joint syndrome. And this is the vertebra, you see the intervertebral disc, very simple. And you see the joint having some of the capsule and joint cavity, the facet joints. Yes, my dear. So if the facet joints is irritated, means the inflammation, means the facet joint arthritis. You see the facet joint. So this is the facet joint, my dear. So only the word they need to remember, that increased with the extension of the, yes, the extension of the thigh, my dear, extension. Yes, facet joint. So once again here, this is the disc herniation, my dear. Disc herniation, the different types here. You can see the disc herniation on the posterior. The herniated disc compressing the nerves. You see the nerves. Yes. And bone spurs here, the bony overgrowth that can cause the spinal canal stenosis as well. But this is the herniated disc compressing the nerve root as well. Yes. Herniated disc. This is the lateral. You see the herniated disc compressing the left lateral side. So yes, so these are the yes, you see the spinal canal stenosis, you see the spinal canal, there's the vertebra, you see, you can see the within the vertebra is the spinal canal and the spinal cord, and this tissue is surrounding the spinal canal, the tissues are there. So some degenerative changes that can cause the spinal canal stenosis and compressing the spinal cord. So I'd like to give some of the SS boxes minor for the low back pain. As I said, the red flags. So the red flags are young, old, malignancy. This is important. Young old malignancy and the fuse night trauma. Or fuse trauma night. Yes, my dear. Fuse trauma night. So write on the red flags. Now, my dear, I'd like to give one of the important talk. The low back pain. Whenever people comes forward with low back pain, the one thing you need to do, whether it's the patient having any morning stiffness or not. Yes, my morning stiffness. Low back pain with the morning stiffness is positive. Definitely this is the medicine pain, my dear. Morning symptom, medicine, my dear. No morning symptoms is a surgical or mechanical. Means the mechanical, means the structural disorder rather than a medicine disorder, functional disorder. So the morning stiffness present, you can see the basically the arthritis, means the inflammatory. I'm talking about the inflammatory pain. So this is the differentiating point in between the inflammatory and mechanical low back pain. Arthritis inflammatory means the medicine, you need to treat the medicine, and this you will treat by surgical if needed some surgical procedures. So this is your patients or not, just to categorize in between morning symptoms, medicine, evening symptoms, all right, surgical, means the structural disorders, minor. So this is one of the important talk that you need to do, the first box and the second box. Turning back to the low back pain, as I said, some of the important box, minor. I say the facet joint syndrome, my dear. So you need to remember the single word, the extension. In your scenario, if you see the extension, words the pain, so definitely the facet joint syndrome that you need to think about. Yes, my dear, this is very much important. Next is the spinal canal stenosis. Very much important, my dear. So we talk about the patient having the claudication. Claudication means if the patient walks, they feel pain in the legs, my dear. So claudication leg claudication. So you need to think about the two diagnoses. Once again, leg claudication, you need to think about the two diagnoses. What is the diagnosis, leg claudications? Definitely you should think about the spinal canal stenosis, SS, and the peripheral arterial disease. So very simplified ways of differentiations that we can do in between these two, my dear. So if you walk for a certain period of time, you stop. Means that walking increase the pain. So increase the pain with standing and reduced with the sitting. Rather than standing, you can write down. Yes, my dear. Standing, rather than standing, you need to walk, means the walking, my dear. After walking, you feel the leg pain, my dear, or leg weakness as well. Similarly, it relieved with the sitting, and it's said that sometimes the crouching down, stooping forward, so it will help. So the sitting is important, and also another important, walking uphills. If you walk uphills, then you will feel some relief. So these kind of differentiations will not be here in peripheral arterial disease. So this is called the neurogenic claudication. This kind of syndrome means the increase and reduce and relieved by some positional changes. So this is called the neurological claudications, which will not be present, means the absent in peripheral arterial disease. So claudication, yes, the most important part, as I say, the claudication is the leg. Once again, as I said, the neurology, the spinal canal stenosis, the neurological pain is a vascular disease. So it's because this is the vascular disease, so the pulses will be absent, but here the pulses will be present, my dear. Because these are vascular claudications. So peripheral arterial disease is a vascular claudication. In contrast, this is neurogenic claudications, my dear. Neurogenic claudications. So this is the basic difference. This is the 5-star, very hot topic for the exam, to differentiating between the spinal canal stenosis and also the claudications, my dear. And another thing, this is very much important, as they say that the low back pain, the morning stiffness, arthritis, the seronegative spondyloarthritis, my dear, means especially the ankylosing spondylitis. You should think about it. Yes, my dear. And also, this is very much important, that another mechanical pain means that there will be no morning stiffness other than the facet joints, and also the claudications, means the spinal canal stenosis, the lumbar disc prolapse, my dear. Means the disc prolapse, means the prolapsed disc. And these prolapsed disc, how can you understand? The most commonly the lumbar joints, and this is occurred in the posterior lumbar intervertebral discs. So these discs prolapse in the different varieties. Sometimes the central prolapse, sometimes the anterior, lateral prolapse, posterior lateral. Posterior is the most common, that's why posterior. And sometimes the vertical prolapse also happening. So forget them. Just remember the prolapse intervertebral is the posterior, so that's why prolapsed lumbar intervertebral. These are posterior lumbar or posterior lateral, you can remember. the lumbar intervertebral disc, my dear. So prolapsed lumbar intervertebral disc is the lumbar zone. So what is this? We can understand. Is it in the lumbar 3? Is it in the lumbar 4? Is it in the lumbar 5? Is it in the S1? So the single word 3 is a knee, just remember. 4 is a down to the floor, down to the floor. Yes. And L5 is the dorsum of the foot. Just write the dorsum. And S1 is a lateral border. S1 is a lateral border. So this is very important, my dear, to know the sensory loss. So the sensory loss will be the knee and floor. Floor will be the medial malleolus. Yes. And the knee means the upper or lower lateral lower thighs. Yes. And L5 is the dorsum of the foot, and S1 is the lateral border. So depending on these pictures, my dear, so you can remember the level of the prolapsed disc, my dear. So I have a box here, the number 1, the low back pain, the recap with the red flags is very important, my dear. Red flags are young and old. Young means less than 20, old means more than 50. History of malignancy, once again. And once again, F for fuse, bundle pack, fever, fatigue, weight loss, sweating, and having the trauma, as I said, and night or nocturnal pain. So this is the box once again. The low back pain once again is the morning stiffness. Once again, the arthritis and the mechanical morning stiffness presence. Think about the seronegative spondyloarthropathies. And once again, the third, once again, this is the first box, this is the second box, and this is the third box. As I say, the facet is an E for extension. And once again, the number 4th is an important claudication diagnosis, spinal canal stenosis and vascular once again. And the difference in the neurogenic claudication means the increase with standing and walking and reduced with sitting. Remember, and also a little bit exception is the walking uphills. Walking uphills. So here is the reverse of the downhills. So it's a reverse thing. Just remember, relieved with the walking uphills. If you walk uphills, you'll feel relieved with the spinal canal stenosis. So these things will be absent in case of vascular, but the vascular means the pulses will be absent here, means the pulses will be absent and pulses will be present with a normal, my dear. Yes. And the last box, the number 5th box, is the prolapsed intervertebral disc. Depending on the levels, my dear, you can think L3 knee, L4 floor, down to the floor with the medial malleolus, and L5 the dorsum, and S1 lateral border. Depending on that, you can make the diagnosis. So the next topic is Iliopsoas abscess. Abscess is a basic surgical topic, the 1-star topic, my dear. So staph aureus is the most common, you need to remember. And secondary causes, commonest cause is the category Crohn's disease. So the word that I am telling you just need to remember. Yes. Clinical features and clinical examination, supine position. You see the psoas abscess patient in the supine position with the knee flexed, with the hip mildly externally rolled. Specific test to diagnose ill. Place hand proximal to the patient's ipsilateral knee. Ask the patient on the left thigh against your hand. This will cause the pain due to the contraction. So lie the patient on the normal side and hyperextend the affected hip. Hyperextend the affected hip. This shows. So hyperextension elicit the pain. Psoas muscle stressed. CT abdomen is the diagnostic chain. Yes, abscess, and of course, drainage the initial approach and successful around 90% surgery. Indicated failure to drainage and presence of other intraabdominal pathology. Seronegative spondyloarthritis is more than 5-star. More than 5 stars is 7-star. Yes, my dear. Very important hot topics, my dear. So reactive arthritis once again is a 5-star topic, my dear. And MCP, not needed, my dear. So the very important lecture, reactive arthritis once again, more than 5-star. Yes, give the 5-star. And the keratoderma blennorrhea is the photograph that you can see. This is the blennorrhagica keratoderma. So yes. So ankylosing spondylitis, more than 5-star, 7-star. Ankylosing investigation management, very hot for the exam, 7-star topic. You can see the bamboo spine. You see the bamboo spine. Yes, my dear. You see the. Yes, the single radiological pictures, the Drager sign, called the Drager sign, detected in both sacral joints. And here you see the well-formed syndesmophytes. You see the well-formed syndesmophytes. Yes. And And here is the lateral cervical spine, complete fusion of the anterior and posterior elements in the ankylosing spondylitis, so-called the member spine. Yes, you can see the member spine. So here we can see the fusion of the bilateral sacroiliac joint. You can't see the sacroiliac joint. You see, it is typically fused. You can't see. So fusion, yes, asymmetrical early stages, but it's bilateral and symmetrical in the late stages. Syndesmophytes and squaring of the vertebral bodies. You can see, yes, syndesmophytes. These are the syndesmophytes and squaring of the vertebral bodies. And as a thiopurine is considered the full blood count if the infarction bleeding is a triple star. Is a triple star to it, yes. Mycophenolate mofetil, once again the M for mycophenolate. You can see the mycophenolate mofetil is nothing but the monophosphate, the single word you need to remember. Psoriatic arthritis is inflammatory arthritis, psoriasis, and is classified as one of the 7 spondyloarthropathies. It is a more than 5-star symmetrical polyarthritis. Of course, very similar to RA type is the most common, the 5-star asymmetrical oligoarthritis. It was thought that earlier the asymmetric oligoarthritis is the most common type, but then nowadays definitely psoriatic arthritis, the RA type is the most common. You'll get the lectures, video lecture, other signs, the psoriatic skin lesions, psoriatic skin, circle the skin, and psoriatic periarticular disease, circle. Tenosynovitis, soft tissue inflammation resulting in the enthesitis, and also tenosynovitis and dactylitis. So yes, and the nail changes, you'll get the lecture slide there. The radiological changes, of course, you need to learn. For the psoriatic arthritis, I'm writing a box, psoriatic arthritis. So you need to learn the unusual combination of the coexistence of the erosive changes and new bone formation. Often have unusual combination of erosive, means because psoriatic is very close, it look like the RA and PSA. So some R for rosing, very close, means the erosing changes and new bone formations with new. So unusual combinations. And of course the RA type you need to remember, and P4 you need to remember, P for periostitis, you see the P for, and penicillin cup appearances. Periostitis, and of course the pencil in cup. So periostitis, rosing, periostitis, and pencil in cup. Management, once again, following the difference are noted: mild peripheral arthritis, mild axial disease may be treated with just NSAIDs rather than all patients being to the disease modifying, as like in rheumatoid arthritis. If more moderate disease, methotrexate is typically used. Use of monoclonal such as ustekinumab. Target is I said that ustekinumab, you can put the I, so I for interleukins 12 and interleukin 23. So and the secukinumab targets the interleukin 17. So you can put one box here, the use 12, 23, and second is a 17, remember. Another one is the apremilast. Yes, my dear. Apremilast is a premilast, remember this, phosphodiesterase type 4 inhibitors. So another one is the apremilast, so write on the premilast and the box. So this is interleukin, ustekinumab and secukinumab. So the premilast is a P for phosphodiesterase inhibitors, type 4. Yes, phosphodiesterase type 4 inhibitors. So mechanism of action is very hot to be with the exam. So suppression of the pro-inflammatory mediators, and promotion of anti-inflammatory mediators has a better prognosis definitely than that of the rheumatoid arthritis, because it's not typically rosing type. So these two interleukins that you need to remember, the US1223 and SAC7 minus SAC7, and premelast means the apremilast is a phosphodiesterase 4 type inhibitors. So these are nail changes. You can see the pitting, raging, discolorations, and sometimes the onycholysis. So yes. So here is the nail changes. You can see some of the X showing the change in the psoriatic arthropathy. Note that the dips are predominantly affected here. The dips are affected, you can see. So here is also some photograph is given. You see the X shows changes affecting both pips and dips as well. Yes. Yes. So the close-up image is extensive in the large eccentric erosions and tuft resorption and progression towards the pencil in cup. So yes, the pencil in cup. Yes, my dear. So the best is very hot, more than 7 star. You should polymyalgia more than 5 star, polymyositis more than 5 star. Seen in around 20% patients and indicates a poor prognosis. Interstitial lung disease is important. In polymyositis, 20% patients, interstitial lung disease. You need to remember. So investigations as well, management, high dose corticosteroids, high dose. These are the important things. Polymyositis is a polydose, remember. Polymyositis is a polydose. Azathioprine steroid sparing agent. So polymyositis, polydose means the high dose. This is the box, my dear. Dermatomyositis, similar things, more than 5 star. Dermatomyositis investigation 5 star. Rickets is not actually, yes, this basically the clinical science, but this is a very 5-star topics, my dear. We'll have a lectures. And here is the features, aching in the bones, joints, and low vitamin D levels, definitely. And osteomalacia, once again, is the clinical science. We'll have a lectures 5-star. Some hypophosphatemia rickets, we will call the vitamin D resistant rickets. Some celiac disease. You have to remember these are the new things. Treatment, vitamin D loading dose, need initial calcium supplement. Vitamin D supplementations here. So this is basically 1 star. You can read very easy things. Osteoporosis causes more than 5 star. And here is the medications worsen the osteoporosis. These are new 2 drugs are added, my dear. Yes, yes, my dear. The 2 other drugs, SSRIs and antiepileptics, are the drugs to be added in the risk factors of osteoporosis. Osteoarthritis management was in topical NSAIDs is the first line. Analgesics may be particularly beneficial for patients with osteoarthritis of the knee or hand. Nice guidance. Say second line is oral. So the topical and oral. A PPI should be co-prescribed with NSAIDs. Nitrogen, we do not offer the paracetamol or weak opioids unless, yes, they are only used infrequently for short time. Pain relief and all other pharmacology treatments are contraindicated, not tolerated. Glucosamine and strong opioids are not recommended. Yes. Non-pharmacology treatment options include the walking aids for knee and hip osteoarthritis. Intra-articular steroid injections may be tried if standard pharmacological treatment is ineffective. Patients should be aware that they only provide short-term relief, the 2 to 10 weeks only. The conservative methods fail. Then refer for the considered joint replacement. Yes, my dear. So you can write the osteoarthritis management plan. So topical, then oral, yes, topical NSAIDs, then oral, and definitely this is important, the intra-articular steroids. The intra-articular steroids is say that only the 2 to 10 weeks only benefits. Then the TKR, total knee replacement or knee replacement actually. So these are the steps for the osteoarthritis that you need to learn, my dear. And osteopetrosis is a 1 star, basically 1 star. Topic osteopetrosis is a marble bone disease. So the rare disease or defective osteoclast. So the osteopetrosis is a class function, the failure of the normal. Results in the dense, yes, mind. Petrosis means the dense, thick bones that are prone to the fractures. Bone pains and neuropathies are common. Calcium phosphate, all are normals. stem cell transplantation, interferon gamma have been used for treatment. So osteopetrosis, you need to remember the osteoclast failure. You can see the de facto osteoclast function. No osteoclast function means no osteoclastic resorption. So there will be no resorption, but there will be definitely the bones will be the dense, thick bones, leads to the fractures. Yes, my dear. So these are the petrosis. So in that case, we say the stem cell transplantation or some gamma interferon can be osteopetrosis. There's osteoporosis, the 5-star DEXA scan osteoporosis management. Once again, the NOG updated the guidelines 2021. Nice clinical knowledge guidance summaries have a section on the management of osteoporosis, largely based on the NOG guidelines. Remember that osteoporosis is usually asymptomatic until a fracture occurs. When thinking about the osteoporosis management, it's useful to think about a number of potential clinical scenarios. A patient who has been identified as being at high risk of fragility fractures based on a Q fracture of FRAC score. Yes, my dear. So a patient who has been identified as being at high risk of fragility fractures, who is being to start the treatment that puts them at significant risk of developing osteoporosis. So risk of osteoporosis. The most common example in the longer term, glucocorticosteroids. And a patient who just had a fragility fracture. So the three things, mind you, had a fragility fracture, having high risk of fracture, having high risk of osteoporosis, the three things, mind you. So fragility fracture, osteoporosis, and also high risk of osteoporosis, high risk of fractures. Yes, mind you. General management points. Of course, the points, the lifestyle, sufficient diet, secondary cause of osteoporosis should be considered. Hypogonadism in women or man, hormone replacement therapy for premature menopause. Bisphosphonate is the first line treatment. At risk of fragility fracture, denosumab is generally used as the second line. Other possible treatment options are the strontium, raloxifene, teriparatide, and romosozumab. Critical scenarios, fragility risk factor assessment. Yes. If the patient deemed high risk based on the fracture score, the DEXA scan to assess the bone mineral density, threshold defining osteoporosis T-score less than -2.5. Some patients may not be suitable BMD assessment due to frailty. General osteoporosis management is about oral bisphosphonate, the first line. Postmenopausal women managed at more equal 50 were treated with the oral glucocorticosteroids. Yes. And a postmenopausal woman managed at more equal 50 has a symptomatic osteoporotic vertebral fractures and hip fractures in the older adults. Yes. In older adults, a hip fracture is manifesting osteoporosis. Yes, the bisphosphonate should be given first line. Yes, the NOC because the IV is zoledronate, but local guidelines may vary and oral bisphosphonate the first. Follow-up plan to prescribe the oral bisphosphonate at least 5 years, intravenous bisphosphonate for at least 3 years, and reassess the fracture. Supplementary treatment, notes, my dear, the bisphosphonates. Yes, my dear. And also the denosumab and the raloxifene, and also strontium ranolate, and the teriparatide, and romosozumab. This is a new drug. The MAB is a monoclonal antibody that inhibits the sclerostin, thereby increasing the bone formation and decreasing the bone resorption, the dual action. So increasing the bone formation, decreasing the bone resorption. Double action significantly improves the bone density, raises the fracture risk. So romosozumab, denosumab. So this is romosozumab. Yes. MRI showing the osteoporotic fracture. Yes, you see the here and also here. Yes, this is here. The 10th and 12th thoracic vertebra. Yes. You can see here, right. Osteoarthritis of the hands, is sometimes referred to as nodal arthritis. Is one star topic, but not very important. Yes. So usually bilateral, episodic joints, stiffness, painness, nodes, bony swelling, Haberden's nodes at the deep joints. Scoring of the thumbs, functionally patients do not usually have problems. One star topic, investigating X-ray, radiological osteophytes, always joint space narrowing. So denosumab is a 5-star topic, it's a very hot topic with exam. Lactus will give an osteoporosis, glucocorticosteroid. Once again, triple star, ANCA-associated vasculitis, once again, the 5-star. Very hot topic with the exam. Yes. Vasculitis more than 5 stars, very hot topic, very good discussions. Polyarthritis nodosa, very good discussions, my dear, 5-star. And here is the topic, you see the renal angiogram. Patients with polyarthritis nodosa, both kidneys demonstrate bleeding and numerous microaneurysms. You see some bleeding and microaneurysms that you can see. So yes, my dear, the chronic fatigue syndrome, once again, the 3 months, triple star topic, my dear. Chronic diagnosis, NICE published the diagnostic criteria. And diagnosis typically made if the symptoms persist for 3 months. This is one of the important topics. Specialist chronic fatigue syndrome service is the diagnostic criteria made and symptoms have persisted for 3 months. And energy management, self-management strategy that involves physical activity and exercise. Do not advise people to undertake the exercise. That is not part of the program overseen by CFS specialist team. Cognitive behavioral therapy, yes, my dear. Nice stress. This is supportive rather than curative for chronic fatigue syndrome. It's a better prognosis in children. And other features are Ehlers-Danlos syndrome. Once again, yes, my dear. E for you need to remember the 3 type collagen E is a 3. And one of the important joint hypermobility, definitely recurrent joint dislocations, easy bruising, aortic regurgitations, angioretinal streaks. Yes, my dear. So hypermobility, circulate, and angioretinal streaks. Osteogenesis imperfecta, presence in the 1-star topic by adjusted calcium parathyroid, or usually normal. This is important, my dear. All calcium metabolic. Mixed connective disorder is a 5-star topic. It's a very hot topic for the exam. Video lactose you'll get, my dear. Once again, and McArdle disease, once again, 5-star. The things that you need to remember, the McArdles, once again, the M4, you need to remember the type 5 glycogen storage disease, myophosphorylase deficiencies, muscle glycosenolysis, muscle pain, muscle cramps, myoglobinuria, and low lactate levels during exercise. Yes. And myopathies, once again, the symmetrical, the single word that you need to remember, and causes are inflammatory, inherited, and endocrine. So 3 I's, and alcohol. Yes. Sclerosenthoma elastica, once again, the retinal angioid streaks. Yes, elastica, angioid streaks, the plucked chicken skin appearances. These 2 things you need to remember. Bisphosphonates, once again, the 5-star. It's a very important topic, my dear, 5-star. Yes. Bisphosphonates is a 5-star, I'm telling you. Bisphosphonates is a phosphopyrophosphate. A molecule which decreases the demineralization of the bone. Inhibit the bisphosphonate, the osteoclastic inhibition, my dear. Reading the recruitment and promoting apoptosis. So clinically use the prevention treatment of osteoporosis, hypercalcemia, Paget's disease, and pain. Now get the adverse effects. I said the bisphosphonate has got the double O, you see. So O means bisphosphonates. O means, yes, 2, my dear. You need to remember O for esophageal, O for osteonecrosis of the jaw. Esophagitis, esophageal ulcer, especially the alendronate, you see. And the osteonecrosis of the jaw, here is some notes, sir. New idea. Substantial greater risk in patient receiving the IV bisphosphonate, IV. In the treatment of cancer, then for the patients receiving the oral bisphosphonates for the treatment of osteoporosis and Paget's disease. Poor dental hygiene. So, poor dental hygiene. Circle the poor dental hygiene and IV, the risk factors. And BNB advised the old patients with cancer and patients with poor dental status have a dental checkup before the bisphosphonates treatment. So this is a new adding my dear. So other things, you see these two important things you need to remember, and also the stress fractures with the proximal femoral shaft, acute phase response, sometimes the fibromyalgia, arthralgia may occur, and hypocalcemia due to the reduced calcium efflux. Three new things, yes, my dear, bisphosphonates. So as I said, my dear, so bisphosphonates, having the bisphosphonates, you see the O phosphonates. So these two O with the esophageal reactions and osteonecrosis, you can remember. But other than these bisphosphonates, these two O, then you need to remember the before bisphosphonates, the before starting the dental checkup. Yes, these are risk factors, and of course the IB bisphosphonate, the risk factor of osteonecrosis. And other things that you need to remember, the stress, acute phase response, and hypocalcemia. So these are the SAC that you need to remember for the bisphosphonates box mylic. That's it. And we have suggested that the tablets should be swallowed, yes, and that should be wait 30 minutes. Yes, my dear, 30 minutes after taking. Hypocalcemia vitamin D deficiency should be corrected. This is important. 5-star before starting. Yes, giving the bisphosphonate. However, when starting bisphosphonate treatment, osteoporosis calcium should only be prescribed with dietary intake. Vitamin D supplements are normally given. The duration of bisphosphonate treatment varies according to the level of the risk. The authorities and stopping bisphosphonate at the 5 years following apply. If the patient is less than 75, femoral neck score less and low risk according to, yes. So some authorities recommend stopping bisphosphonates at 5 years if the following apply. Adhesive capsulitis is that diabetes mellitus circle, diagnosis is clinical, although imaging management, no single interventions has been treatment, anesthetics, physiotherapy, oral corticosteroids, and intra-articular steroids. And the Langerhans cell histiocytosis. Yes, my dear doctor, the most important topic is the Langerhans cell histiocytosis. Basically, this topic is a multi-system disorder, so it's a very complicated disease, rare disease, but yes, has gotten lots of differential diagnosis can be associated with this disease, my dear. So that's why this Langerhans cell histiocytosis is a less important topic in part 1, but more important in part 2 written, my dear. So yes, this I will talk a little bit. You see, the Langerhans histiocytosis is a rare disease characterized by the proliferation of the Langerhans cells. Is nothing but the phagocytic cells, specialized dendritic cells. Normally function to the present antigen to T lymphocyte. These can affect the multiple organs, including the bones, skin, lungs, endocrine system. It is notable for its variable clinical presentation, ranging from isolated bone lesions to multi-system disorder. Features of the bone pain, typically the skull and proximal via cutaneous nodules. Pituitary involvement, you see, it leads to the diabetes insipidus due to the pituitary stop involvement. Pulmonary involvement, more common in the latter, presenting the dyspnea, cough, chest pain, recurrent otitis, medium musculitis, and also Tenix racket-shaped Birbeck granules on electron microscopy. Racket-shaped Birbeck granules on electron microscopy, yes. And diagnosis of biopsy confirmed is through the biopsy showing the Langerhans cells with characteristic grooved nuclei, one of the points, the grooved nuclei, and positive staining of the cell surface protein like the CD1A and S100 protein, my dear. And also the imaging radiographs and MRI, bony lesions, CT may be used for the chest and abdominal involvement. So imaging is needed. Treatment localized, yes, localized disease, surgical resection, limited radiotherapy, multi-system disease, systemic therapy, steroids, chemotherapy, beam blasting cytotherapy, targeted therapies for refractory cases. Supportive care, management of diabetes insipidus, pain control, and treatment of secondary infections. You see one of the skull photograph is important for part 1, that you see the osteolytic skin, osteolytic lesions, yes. So multiple well-defined punched out punched out osteolytic lesions with the scalloped edges or geographic skull are seen in the bilateral parietal regions, and the lesions has a characteristic beveled edges. So there is a typically the histiocytosis X, or the previous name of the histiocyte is X and the new name is the Langerhans cells histiocytosis. The histiocyte X or Langerhans cells histiocytosis. The new name idea. So I will give one of the box idea. Langerhans cells histiocytosis basically is a triad. I'm giving a triad box so that it will be helpful. So L for, just remember, lytic bone lesions. Langerhans cells history LCH. Yes, my dear. So the C for, yes, C for CDI means the cranial diabetes insipidus because of the pituitary stalk is compressed and pituitary stalk involvement. Yes. So the CDI you can remember, and of course I am giving the triad, and the H for is the hyper. I'm telling hyper means the exophthalmos, means the proptosis. Yes, my dear. Hyper means the exophthalmos. Just remember, hyperthalmos or exophthalmos. So this is the triad, but this is not always present, this triad in the Langerhans cells osteosis. The multi-system disorder, it can affect so many things, but you need to remember this: lytic, bony lesions, CDI, hyper, exophthalmos. Lytic, bony lesions, C for CDI, cranial diabetes insipidus, and yes, H for hyperthalmos means the exophthalmos spider. You need to remember. And most importantly, as I say, the LCH diagnosis is the biopsy. So the biopsy, once again, C for CDI, C for basically the disease of the C. You will see in the part written, but here I'm giving the C for the CD. Yes, my dear, CD1A, the surface protein, and CD207. It is not here in these notes. It is called the langerin. The another name of this protein, my dear. And another is a S100. So these proteins, surface protein diagnosis, positive staining for the surface protein, the diagnostic, and definitely the cell is the Langerhans cell. So the cell you need to see, and cell has got the grooved nuclei. You need to remember. So this is the things that you need to remember. And the treatment are, once again, you see the systemic corticosteroids, chemotherapy, and cytarabine. So CCC. This is another treatment box that you can see. The treatment is the CCC. Yes, my dear. That's it. So once again, the triad, the LCH, the CDI, that you need to remember CDI, and of course LCH, the diagnosis, once again the box with the CD, and treatment is the CCC, my dear. I hope that you enjoy it. Ankle injury is osteoporosis, once again the one star topic, my dear. Not very important, so just have a quick read. The avascular necrosis is the 5-star, which things the MRI, the thing you need to remember, and the joint replacement may be necessary. That's it. Carpal tunnel syndrome is the clinical signs. We'll do study there. 5-star topic, not here. And the cubital tunnel, the cuts, once again, is a 3-star topic. We'll have a lecture, my dear. Yes. Dactylitis, once again, 1-star, 1-star. Osteomyelitis, once again, the 5-star. But the most important thing is that it is Staph aureus, the most common, MRI, and cloxacillin clindamycin. That's it, my dear. You need to remember. Decurvans tenosynovitis is a fecal stain tenosynovitis. The tenosynovitis is the tendon shape, so it will feel the pain in the longitudinal traction. Yes, you see, the examiner pulls the thumb of the patient in ulnar deviation. So this is the radius, this is the ulnar. So ulnar deviation. Pull the thumb of the patient in the ulnar deviation, longitudinal traction. In a patient, tenosynovial reaction causes pain over the radial styloid process along with the length of the extensor pollicis brevis and abductor pollicis longus. So these stains is once again the tenosynovitis. So here's why the doctor. So the decurrent tenosynovitis is also a one-star, double-star topic. So steroid injections sometimes will help. Elbow pain is a less than one-star topic, not very important. Just go through the questions he's focusing here. Familial material fever is a 2-star or triple-star. Familial material fever is also known as a recurrent polyserositis. So basically, serositis is an autosomal recessive disorder, typically present by the second decade. It is more common in people with Turkish, Armenian, and Arabic, circled Arabic. So the features typically 1 to 3 days. So I'm telling that 2 days. So the serositis, the pyrexia, pain, pleurisy, pericarditis, and perisynovitis, you can write down, and C-piloid rash, pericypiloid or piloid rash, you can say. So all the P's that you need to remember, that's it. Pyrexia, pain, pleurisy, pericarditis, peritonitis, less common, but yes, the periserositis means the synovitis, and piloid rash, and management is a pulsicide may help. Done. So you see the recurrent polyserositis has a relapsing polychondritis. It's a multi-system condition characterized by repeated episodes of inflammation and deterioration in cartilage, affecting the ear side. The most common ear can affect the other parts of the body, such as nose and the joints. So the ear-nose joints, you can say. So ear, ENT department, basically they go the ears, auricular chondritis, hearing loss, vertigo, and nose nasal chondritis, saddle nose deformity, yes, nose, yes, and also lower respiratory tract, the hoarseness, aphonia, wheezing, inspiratory stridor, and also the joints is an arthralgia. So yes, these are the important involved the relapsing polychondritis. So the polychondritis is based on nose, ENT department, ENT, we can three about, right? So E, yeah, nose and throat, of course. But I'm talking the tract, means the lower respiratory tract is the most important. Nose, okay, fine, nasal saddle nose, ear is a features, nose is a feature, and throat, but here's the tract, the respiratory tract. You need to remember these and tract. And these two important means the respiratory tract, hoarseness, aphonia, wheezing, inspiratory stridor. So this is serious effects minor. That is important. So stridor, single words that you need to remember. And also the joints, then arthralgia, arthritis or arthralgia. So this is ENT, you just remember. Diagnosis, various scoring system based on clinical, radiological, pathological treatment include remissions, steroids, and azathioprine, methotrexate, cyclosporine. Fibromyalgia is once again the 1, 2-star, 3-star topics. Women are affected 5 times likely affected 30 to 50 years. Chronic pain, multiple sites, sometimes pain all over. Lethargy, cognitive impairment, fibro, fog, sleep disturbance, headaches, dizziness are common. Diagnosis, clinical, and sometimes referred to the ACR criteria, which lists 9 pairs of the tender points on the body. As the tender, it lists the 11 of these 18 points. It makes the diagnosis fibromyalgia. The management of the fibromyalgia is often difficult and needs to be tailored to the individual patient. Psychosocial, multidisciplinary approach is helpful. The following is partly based on the conscientious guidance of the Euler guidelines published in 2007, also BMG review. Explanation, aerobic exercise, cognitive behavioral medication, pregabalin means the neuropathic, yes, minor, the neuropathic pain diagnosis that we call the DAG and GAT. GAT means the gabapentin, yes, minor, amitriptyline and D4-duloxetine, yes, and all the GABA drugs. Hip pain in once again 1-star, less than 1 star is not very important, my dear. Just go to melalgia parasitica. Once again, we'll do study in the neurology. This is yes 5-star, yes, my dear. And the lateral epicondylitis is once again less than 1-star. Rotator cuff muscles are 1-star, has the mnemonics is a cyst, so just 1-star, my dear. Hormone replacement therapy adverse effects, yes, increased risk of breast cancer, increased by addition of a progesterone. Yes, my dear. Potential complications. Temporal arteries is a 5-star topic. It's a very important topic. 5-star. You see, the giant cell arteries, vasculitis of unknown cause, medium, large vessel vasculitis. It occurs those over the 50 years. The giant cell arteries. Giant cell is the 50 by 50 minor, equal to 50 by 50. Yes. So it requires a recognized treatment, minimize the risk of complications, permanent loss of vision. That is the most important message, my dear. You must know about it. Hence, the temporary suspected treatment must be started promptly with a high-dose prednisolone as well as an urgent referral for assessment of the specialist. There is an overlap in between the temporal arteries polymyalgia with the giant cell arteritis and PMR. Around 50% patients have the features of PMR. Typically, patients more than 60, jaundice, jaw claudications. Yes. Vision testing is a key investigation in all patients. This is the most important message because the anterior ischemic optic neuropathy, yes, mind, accounts for the majority of the popular manifestations. It results from occlusion of the posterior ciliary artery, A branch of the ophthalmic artery ischemia of the optic nerve head. Fundoscopy typically shows a swollen pale disc. May result in temporary visual loss, hemorrhagic fugax. Permanent visual loss is the most feared complications of temporal arteritis. May develop suddenly. Diplopia, double vision may also result from the involvement of any part of the oculomotor nerve system. Tender palpable temporal arteries, 50% have features of PMR, also lethargy, depression, low-grade fever. Investigation raise inflammatory markers, ESR more than 50. CRP may also temporal artery biopsy, skip lesions. Means sometimes you cannot get the biopsy findings can be normal because of the skip. Treatment is an urgent high dose course should be started as soon as the diagnosed suspect with the temporal biopsy. No visual loss, high dose prednisolone is used. If there is evolving visual loss, IV methylprednisolone is usually given prior to the starting high dose prednisolone. There should be a dramatic response if not, diagnosis should be considered. Urgent ophthalmic review, definitely. Patient visual symptoms should be seen same day, yes, by an ophthalmologist. Visual damage is often irreversible. Other treatments, bone introductions, because of the steroids, bisphosphonate is required as long tapering course of the steroids required. Low dose aspirin sometimes given the patient as well. All the evidence-based support is weak. Greater trochanteric pain syndrome is the GTPS. It's a 1-star emerging topic. Greater trochanteric syndrome is also referred to as a trochanteric bursitis. Yes, my dear. It is due to the repeated movement of the fibroelastic iliotibial band. Repeated movement of the fibroelastic iliotibial band is most common in women aged 50 to 70 years. Pain over the lateral side of the hip or thigh, so the lateral. Tenderness over the palpation of the greater trochanter. So the pain, lateral side, means over the trochanter, tenderness over the trochanter. Very simple. Yes, my dear. And the SS bullets are very important, my dear. I hope that, my dear, this lecture discussion, after having this summary, yes, my dear, you have an idea of all the overall topics and the importance of the 5-star, 4-star, 3-star, 1-star topics. And the topics are discussed here. The SS boxes are given also here. And now you are ready to start your video lectures, my dear. I hope that you enjoyed. Thank you very much.